thinking more about, that multi-system illness, that whole patient complex, the sickness stuff for that whole patient group. We need our psych help to understand the infectious diseases and post-viral conditions and whatever causes psychiatric presentation.
Yep.
I was so lucky. I've got a beautiful patient at the moment, and she asked me, can I just meet with her psych and talk? And her psych was a beautiful woman. She's been in her 60s, she's been practicing a long time, had no concept that mold caused anxiety, panic attacks, depersonalization, derealization. She had no idea that there was a biological cause for the psychiatric presentation of our patient. And I just thought, oh, what a gap. What another gap that we are suffering because we are reducing the human body into different parts. One is the mind, and that one's the nervous system, and this one you see a gastro for, this one you see a hormone doc for. No, we are one being, and all of our parts are interacting. And we can't just pull them apart and say, oh, well, you're only depression. No, you're not. Is it rickettsia that caused the depression? Let's look at the immune system here.
Yeah. Well, interesting. One of my first major symptoms, apart from severe pain through the shoulders and neck, was actually panic attacks, anxiety and panic attacks.
I see that a lot.
And the very first drug that I was put on was a benzodiazepine, which then I ended up
getting addicted withdrawal to. From, yeah, of course you did.
And now I know that it was the infections that was causing that. Now I've got them under control. I'm now off, thankfully, the benzodiazepines, which took me more than 2 years, and I did not get good medical help to do that because they didn't know what to do about it. Thankfully, I don't think they're just willy-nilly prescribing them as much as they used to, but they can be a lifesaver for some. But they also can be very, very detrimental for many. So I'm glad I finally off them.
And I'm still seeing a raft of perimenopausal women and sudden onset of not being able to sleep at night at all. They're still getting them. How about we look at her hormones first?
Yeah.
Oh, but we can't prescribe hormones in Australia. We can't prescribe estrogen. No, not until she's actually stopped menstruation. When she's menopausal, she can have estrogen, but not when it's up and down or all over town or leaving the building. And she's suffering from it for 10 years first. Why? But, give her benzos instead, then she will sleep. No, maybe it was just progesterone that she needed. Yeah.
Well, there's other things, nutritional deficiencies. I mean, your infections suck nutrition out of you big time. I mean, you're not going to get it only from your diet, even if you change your diet, which I have and many people do, of course. And I found things like magnesium L-threonate, fantastic for my sleep. It took me ages to find that. And that's the only magnesium that crosses the blood-brain barrier. And add to that, it was Cerephos, something else. Again, I've learnt this from patient communities.
Yes.
I learned most things from, I don't believe everything that's been put on there, written on there, but I'll go in and do a deep dive research and go, well, look at this, and then I'll give it a try. It's safe. I asked my doctor. He said, sure, give it. And lo and behold, L-theanine didn't help. Other things didn't help. Teas didn't help. But these two things, I can sleep through the night now, thankfully. And it takes a lot of trial and error, but that's the information that's good to get across to people. They wouldn't have thought of that.
Yeah.
Safe and effective is those things,
But it comes back to cost, though. So many of our patients are on disability pensions. They're not working. They're not eligible for the NDIS, which I think is one of the recommendations that should have been in here. Work out how to get this stuff recognised by the NDIS now. People need help.
To finish this off, I guess, the recommendation that one of the things that I really liked was this. You know how we've got acute care clinics now coming up and cropping up everywhere as well. And there's this to and fro and politically about whether they're cost effective, et cetera, et cetera. But I would love either. I thought chronic care clinics, whereby you've got ME/CFS people and you've got all of these facilities available, especially if they're in the major states and cities, and that start with there, and the poor country people kind of can miss out unless they've got telehealth with that. I thought that's pretty costly to set up and establish. What if you have a functional medicine chronic care network of people? The people could go from being a normal GP into a functional medicine doctor. And that the rebates that the patients get back are a lot higher. So you actually apply for this, and then the functional medicine doctors also apply to be part of this chronic care community, and all of them are trained.
Decent training. That's right. Because again, it comes back to, and functional med docs, they say, okay, you need a SIBO test and a gut map and a Dutch test and an OAT, and patient's $3,000 out of pocket and hasn't got any actual useful information whatsoever for a chronic Lyme disease or chronic tick-borne disease. And I guess, I fully believe that would be a beautiful model of integration, and that's what we need psych care in there. We need behavioural therapy stuff. We need support for our families to love us through this.
Put me in charge of Department of Health for a while. I'll get it sorted.
I know, Pete. I was thinking the same thing.
Wouldn't like to be the Prime Minister or in charge of that. But if they would only listen to the patient community, the patient representatives, the associations as well. So I guess the continuation of advocacy will still have to happen. We'll work alongside the LDAA and others. And we'll have to follow this up and make sure that this is implemented in time frame. Talk to our local politicians. The LDA at the moment, we've got fast approaching an election. We've got people...
Great idea, actually.
Is to contact their local politicians. I will be contacting mine again. I have met with both of mine. Lovely people. And they know about TICNA. They know about what I've gone through as well. I just need to be the squeaky wheel and keep pushing them as well, because they've got, I guess, a lot on their plate. Have to keep backing it. And it makes it difficult when you're already sick to keep doing this. We'd love to have some healthy people involved as well.
Yeah.
Which, if you had cancer, you would have more healthy people involved, but our community doesn't seem to get healthy people helping us, but hopefully that'll change. All right.
Yep. So just the only thing I wanted to double back to, you asked me before, are there other great naturopaths? And I believe there are. Are there others that specialise in Lyme in Australia? If you know of any, I want to hear from them. Please let us know who are these people, because I might want to take holiday leave one day and refer someone.
Well, I do. There is another one I refer, because a lot of people, because I'm president of TICNA, there's a lot of people who contact me through the public page. And I don't make any recommendations or suggestions or offer treatments or anything. That is not my role, not TICNA's job or anything as well. But I do suggest to them to contact yourself, and also another practitioner in Melbourne who's lovely. There's also a functional nutritionist who's got her head around this as well and is willing to take on patients, because we're pretty complex people.
Yeah.
But
not everyone's got the time. Like I
spend hours with them.
People on very, very intensively for the first 12 months we work together, because this is not a patient population where I can just say, take 3 things, I'll see you in 6 weeks.
Yeah.
No. This stuff is so personal, so in-depth, so the cognitive stuff means you need a lot of hand-holding. I need to get to know my patients, and when I do, that's when we get the life-changing results. It's not a traditional kind of business model or therapy model, not at all. It doesn't work if you do it that way.
No, and that's what the government needs to understand about us. We are a chronic illness community that needs a completely different approach that doesn't fit into their round holes. We are square pegs. And I did say that in that term as well. And I don't think it got through to them. They think, and the RACGP feels that their normal GP community can help us out. And I
not for the complex stuff. At acute, yes. In diagnosis, yes.
Maybe.
And enough for them to say, there's enough clues here, I think we should run this test. Yeah. But for actual solutions, the 7-minute appointment model cannot possibly do anything but write a prescription for Lexapro. It cannot help.
No, and
it has to be a new model.
Yeah, sorry. And most of them don't have more than the 7 or 15 minutes that you do get for them. I mean, they're under the pump with a wide variety of people that they see, from young babies with snotty nose, pregnant women, and the whole thing.
The whole lot.
Which comes back to my idea of a chronic community of people who said, look, no, I'm focusing on the chronic illness world. I don't see the normal day-to-day sort of things. My minimum appointments with each people is 15 minutes. If not, most of the time it's going to be half an hour. And for us, if they're going to charge the $250, because they probably need to do that kind of thing, because they're going to be seeing 2 people in that half hour. They would get that kind of money if they saw 10 people at normal rates. So they need to do that to cover all their costs. We need more than the $80 back. We need almost all of that back. I don't know whether they could make it free. That's where it will cost a lot.
That's all outside my
That if they stop more people from entering our world by, doing the prevention campaigns, that's going to be beneficial. Because if they don't, they're going to get more people like ourselves, who are sick because we didn't understand what the tick was or what the infections were, and it'll go on becoming.
And all the first people you went to for treatment had no idea how to recognise them or what to do. The onset of those symptoms, misdiagnosis for a long time in your case.
Yeah, they don't even ask, have you travelled overseas? How long ago did you travel overseas? They don't understand that it could be in your system but only come to light now. I mean, there's so much training that needs to be done with them.
And I don't think it'd take long to do it. I really think they could get a lot of that done in half-day workshops.
Yeah, they would.
As part of their continuing practitioner education stuff, because they don't need to understand all the clinical pathways. They just need to understand how it presents in a patient, what it means, and what they do. It's actually pretty simple to assimilate that kind of level of information into GPs and healthcare professionals pretty quickly. And that's where it comes in. Then we need that next layer of care for chronic illness people, someone who actually specialises in it. So everybody should recognise it, and then it should be a specialty as well. And I'd love to say it's an infectious disease doc that is, but they don't have the breadth of knowledge because they're not gastros, they're not neurologists, they're not psych, they're not all the other stuff that chronic illness needs support with as well. We can't just only treat it as well. If we kill the infection, the body is fixed. We all know that's not true.
And the practicalities of that, even if you do get into infectious disease doctor, you need a referral from a GP. The time process is long-winded, and many of these infectious disease doctors have a minimum of 2 months waiting list, especially in public hospital situations. That is too late.
It is.
You need them within the first 4 weeks of you suspecting strongly that you've been bitten by a tick, or you suspect strongly you've been bitten by a tick.
You've never been well since you've been camping, even though you didn't see the tick. That's right.
Yeah. I mean, the stories that people have gone out camping and woke up with ticks crawling all over them in their sleeping bags for the night.
That's
And look, and there's also fleas. Fleas carry rickettsias.
And then Bartonella, I had a woman in Melbourne got bit by a fox recently, Bartonella.
Look, they've got the capabilities in Australia, which brings me to the story of the guy, which it was only just published the other day. I think it was in the RSCGP magazine. And it was an American who travelled to Australia, and he got very, very sick in Darwin. He went to the hospital there, presented at the hospital, and they asked the right questions. And they found that he came from an endemic area of ticks in that. They ran all the tests. They found out that he had Babesia, I believe, so they can run the tests for overseas testing for Babesia. And they treated him like you would not believe, and he recovered. And he's a tourist coming from America to Australia, got the proper treatment through a hospital.
Got lucky, just got the right doctor on the right day.
We are capable of doing it here.
We really are.
And that was proof positive, and yet it doesn't always happen, and yet it should always happen.
It should do.
Why should it happen to an American tourist?
Absolutely.
As good as that,
Yeah, absolutely. And then the nonsense with pathology. So I've just been watching a circus unfold since November last year. What are we recording now? It's April. So onset of symptoms after camping in Queensland, 18 months goes past. Finally, symptoms are not resolving. All the chronic fatigue, all the flu-like stuff, she's feeling rubbish all day, every day. Gets a GP in far north WA. Finally, somebody runs an intelligent test, comes back rickettsia positive. My next question, takes the 10 days doxy, feels better, finds me. My next question was, can we look at the other tick bites? Like other tick infections. This is a bite in a place that we know there's more than one infection there. Let's run it for more than just Queensland spotted fever and rickettsia.
That's the American one, by the way.
Yes, but we run that here. And I think Benetti maybe, is that? Just trying to picture it in my mind as I'm saying it back to you. So I wasn't planning on talking about this. Send it to a local path lab. There's only one pathology draw in that town. That's it. You just send it to this company. That company held the blood hostage, would not send it on to ARRL, regardless of how many times the doctor called. So now we're wasting doctor resources calling a path lab who were like, oh, we're not going to send it on. We can run those tests in-house. They cannot. They do not PCR for Borrelia in-house at that lab. They do not. And so completely denied the patient accessing testing. Patient has to do another blood draw, patient has to do another herbal provocation, has to go back to the doctor to get another referral for ARRL. Same lab held it hostage again. And now ARRL sent it back to that lab instead of back to the doctor. The patient still does not have the results. And it's just, and I updated an addendum to my Senate submission on that circus. This has been going on since November in one form or another with this lab holding the bloods hostage. And when I put it on my Facebook, so many people hopped into my personal messages saying the same thing with particular labs all around the country, denying them tick testing. The labs themselves, the government-funded ones, are denying care too.
And see, it's great putting these recommendations forward and thinking everything's going to be hunky-dory, but they're not. Your case in point is the practicalities happens behind the scenes, goes on all the time.
Yeah.
And they don't understand where all these failings are, that the nuance of all of this has to be addressed.
Yeah.
And that's a big nuance. It's terrible.
Yeah. Yeah, it's awful.
We've covered a lot of ground.
We haven't even gotten into any of the 100 pages, just the first ones. So
I know, just the recommendation. So look,
I do recommend, if anyone's got the cognitive capacity or the willingness for it, there were some beautiful things that came out of the finding. Just hearing some of the doctors, some of the overseas experts, some of the overseas pathology labs, just the validation. I think it's worth reading. I think it was chapter 4 where some of those things were that were just, it really was nice to hear that we're not crazy.
Yeah, exactly. And it's great that we had a couple of overseas people here backing us as well, wanting to be involved with us, wanting to help us out as well. The Australian government needs to allow that.
Yes.
It needs to take the information, which is far superior to what we've got here, and just transpose that to Australia and Australianise the overseas information.
Yep.
No, it's not different. I know that the ticks are different, the infections are slightly different, but they're going to cause the same kinds of problems as we're seeing with the patients.
It looks the same in the people, so let's use the established guidelines for how we recover the people, because that's the only bit that matters. I actually don't care what's making ticks sick or not sick. I care what's making people sick, and dogs too, probably, and cattle and stuff too. But we need to put the time and the money into what's actually going to get the quality of life improvement.
Exactly. This concept of do no harm by doing nothing is we can't continue that status quo. We have to we have to just treat people, and not just with Panadol and a good lie down. It has to be real serious treatment, off-label stuff, and trial it.
And for a long time.
Yeah. And I'm realising that I'm in the middle of my kind of treatment, and I realise it's going to be at least another 6 to 12 months of ongoing stuff. I'm going to feel worse in between, but there's hope at the end of all of that. And we all need that. We need real hope, not just imagined hope.
No, and because that's the other problem. People come to me and they're so scared to even try because they've been in the circus for so long of hope, dismissal, gaslighting, no results. Then they don't know what to do because they can't keep investing in lies.
Yeah. And someone like yourself acts like a health coach along with them as well.
For me, I do.
And my doctor's pretty similar.
I'm your best friend and your cheerleader when you worked with me too. Like I'm the person you send a message to at 4 o'clock in the morning and say, my baby's got spots all over them. Do you know what it might be? No. Like I'm more than just your Lyme tick-borne person when I'm on your team.
I know. And my GP is pretty similar. He's a lot busy, very, very busy with lots of patients. He's booked out for more than 12 months, sadly. Yeah. He needs to put his knowledge onto a lot more people.
He does.
We need a willing community of doctors. We don't need every GP. We need just a good number of GPs to raise their hand saying, look, this looks to be fascinating kind of stuff. It's
more than one doctor in each state. Like we've got 2 in WA and one of them's retiring. What are we going to do? The other one's not ILADS trained. He's just a decent man who's open-minded. Absolutely.
We need the availability. The thing I thought about this chronic illness, collaborative team was have a local GP who's your secondary doctor. Your primary functional medicine doctor was can look after you. And you didn't have to see him physically each year because so many people are housebound and everything. And let's face it, how many times now when you see a doctor, does he actually physically examine you? It's quite rare. But
Not
if
often.
you've got an ear infection or something local, you could see your second in charge GP who actually has got the same information that your primary care doctor does, and they add to the files. So you go to your local GP and he's able to look in your ear and say, oh, look, you've got an ear infection. I can see that you're on all of these other things as well. So he doesn't, he knows your full history too. And the two work collaboratively together, where your primary one does your most important stuff of your infections and your mast cell stuff, the really complicated functional medicine stuff. And your local GP has an understanding of that. And
they can just rewrite the scripts and make sure the bloods look good at the monthly blood test if you're on azithromycin. Like, they can just do the stuff that keeps it going. And also, can we take input from people like me? Because there's a beautiful functional medicine doctor in Sydney at the moment with a health coach on her team. Health coach is the one you see every 6 weeks. Doctor's the one you see every 6 months. Yep. So she just disseminates that information to the health coach. The health coach is the one that spends the 45 minutes with you implementing it, so you know what you're doing, how you're going, checks it all, does the human care, which we need, but we don't need to tie up that high-level, high expense of the doctor or of the functional overseeing doctor. Let's disseminate that information better.
Yeah, we could probably put together a plan and put a proposal forward as to how to do this, how to solve this problem.
Yeah.
It needs solving, doesn't it?
It does.
And they shouldn't be horrendously expensive kind of things either. We do need patient funding to a high degree to be able for us to afford it. So if it's only $50 out of a pocket, it's more affordable. And we only pay that $50. We don't have to pay the $250. That's another thing with Medicare. Somebody has to come up with that full amount of that $250, and then they get their X dollars back.
And then we need the mycotoxin lab test, which is $600, because then we know if we can prescribe the itraconazole or not. And then we need the overseas Lyme test, which are $2,000. And then we need the GI map. It's just, how can you do it? We need this stuff to be more accessible for everybody.
Well, the RACGP needs to understand these non-Medicare based tests a lot more than they do. They don't understand the naturopath kind of tests that we've got here, which are great, or the overseas tests that we could easily get into Australia. No, it's available here. We're not a third world country. We're a first world country. We've got the capabilities.
I'm going to say criticism of a lot of functional med and integrative med doctors and naturopaths that position themselves in that way as well when they're very heavy on testing. As a clinical naturopath, you can tell what's going on with bodies. As a decent GP who's experienced, you can tell what's going on with bodies. We don't need to always be spending that much money. But the amount of GI maps that come back, and I'm like, of course I can tell what this was going to be. Why did you spend $600 on this? It's working with people who know where to invest the money that's going to get you wins as well.
Look, and that's a valuable part of the proposal. So, look, these are your priority testing. If you've got the finances to the secondary testing, these are ones, if you've got a lot of money and you want to spend them, fine, but you don't necessarily need them. All of that needs to be laid out so people understand that kind of concept.
I think one of the great questions for patients is, how is this going to inform my treatment step? Because data is nice, knowledge is useful, but if your therapist is actually saying, well, I need to have this test because it tells me, can I do this treatment now, or do I have to do X, Y, Z first, and then we put that treatment in? So if it's going to give you an action step, do it. If it's just knowledge for knowledge's sake, because say you do a GI map and you spend your $500, or whatever they are these days, and then it comes back, you've got infections. What infections, were they so specific that you needed to know that actually it's the active ingredient in garlic that targets that versus the active ingredient in oregano, or is it a berberine specifically that treats that? Or could we just try the patient on those things as a naturopath and save them that money? Since we know that herbs have so many different actions and affect so many different types of infections, do we specifically need to know which one? And I just think there's so many ways we can be saving patients money.
I'm going to be a real devil's advocate.
I know you will. Please do, because you're the scientist. So
well, I'm also thinking in regards to APRA.
And that's the problem with the insurance-based model. That's the problem with the regulating body justifying. So if you're then needing a test to prescribe a medicine because you're a doctor, then the testing has to be affordable for your patient.
Yeah, well, that's where it comes back to when I said about APRA, is
It
that
is.
they need, do APRA need a proof of the infection or whatever to justify your providing that treatment. That's, I don't know. I'm not a
They
part of
do,
all of that.
absolutely. And
So-
the American insurance model is absolutely ghastly for that. And they are completely handcuffed by doing very expensive testing to justify getting treatment through their insurance. So yes, APRA does absolutely want in an audit to be making sure that patients have
proof of that.
a test to justify, but then they're not, using the test that we want to be doing anyway as anything.
Yeah, well,
They don't count them.
Again, they have to be a part of this whole conversation as well. And they have to, I guess, get an understanding of these kind of difficulties that we face, because a normal GP goes, I can't run those tests, or I need to run those tests to get the proof for me to give you that particular treatment. See, again, this is another anomaly that we're facing.
What's
this is
actually
another
best for
catch-22.
patients?
Yeah, well, these all need to be discussed and need to be...
And this is part of broader healthcare reform. I feel like with this podcast, like, cut it into sections, do 2 parts for the findings and then one of this, like, end one for, transcript this bit, like, timestamp it.
2.5 hours.
Yeah, like, cut up the 2 recommendation sections as to 2 1-hour ones, and then just have a broader healthcare reform that we would love to see for chronic illness.
So much more we could talk about this, and we could solve the world's problems. I'm sure this could, along with another community of people helping us out. I think we've covered everything. I will add on one point, just back what you said before. The thing that is a little bit annoying for myself is the fact that before you get a diagnosis of ME/CFS and fibromyalgia and or other things as well, there has to be a huge ruling out process of these tick and other infections. I know many people with Ross River virus and Barmah Forest virus who are suffering just as much, and there really isn't any great treatments for them, apart from if you go to a naturopath and do get herbs and so forth as well. But there's no set treatments for them, and they are suffering too. So we do need to really have good testing for all of that, and before you get to these other diagnoses. And these other diagnoses should not be your end point.
No.
If you get the diagnosis, you shouldn't be saying, well, you've now got this, and people go, oh, that's the reason. It's not a reason. It's simply a label that you've got. You've got to go further than that, sadly. And rest and pacing is definitely important for you, without a doubt.
That makes your day feel better. It doesn't cure you.
But you need to start investigating a lot more, which you can do, which can go beyond just tick infections, of course.
Absolutely. Definitely. And I think any of those labels are the CFS-ME, the fibro, POTS, MCAS, they're all those kinds of diagnoses that I'd be strongly advocating people or recommending people to look deeper into the infections there. MCAS, look into mold. Look into mold if you've got MCAS.
There's lots of things that can trigger your mast cell things, heaps of things.
If you've got mold colonizing in your body, you will end up with MCAS at some point. That's my clinical, I'm seeing it 100% of patients at the moment. That's their clinical pathway. So obviously I only see tick-borne diseases and mold. So obviously I'm seeing it in my patients, but that might be applicable to other people with MCAS as well.
Yeah, definitely. All right. We should wrap this up.
Yeah. Thank you for having me.
Oh, thank you for spending the time with us and helping to go over all of that as well. There's a lot involved in it. Look, it is great that we have a second one, for sure.
Yes.
It does mean that our patient community sadly has to follow up on this and make sure that they are implemented. I'm not sure how we're going to go about that. I think that's something that individually perhaps we can talk to our politicians and see what happens with it. Perhaps the Lyme Disease Association will know a little bit more as well. We have to get over this next election, and then we can't just let it rest this time round. We've got to continue pushing and making sure it comes about. The recommendations are good, but we need to see them properly.
If they're actioned and implemented.
In a timely manner, as you said.
Yeah.
Excellent. Goodness me.
Thank you for having me. Thank you for having this chat.
Pleasure.
I think it's useful.
Good having a chin wag, I said. I'm going to reiterate again, this is not medical advice at all. I'll put that on the front of it all. This is just 2 people having a good chin wag, one with a great clinician who knows what she's doing with all of this, and myself with, I guess, with a lived experience of all of this too, and passionate about wanting to try and advocate for change if I can, as best I can. So I'm passionate about that.
Mm.
Right, guys, thanks for listening in. I'll have to break this up, I think.
Yeah, I agree.
All right. All the best, everybody. Thank you. See you.